our meeting for July 20, whatever it is, 26th,
Yeah.
to order, and ask that you call the roll.
Sure. I'll start with you, Commissioner Chow.
Present.
And Commissioner Green.
Present.
All right, I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. Commissioner Chow, I'll call the items. Is that okay with you?
Absolutely. Please call
great.
the items.
So item 2 is the approval of the June 28, 2022 JCC minutes.
Good. So a motion for approval is in order.
So moved.
And we need a second.
I think, Commissioner Chow, I think you would be that because there's only 2 of you here.
Oh, okay. I would second that then.
Great. And we have 1 person on the comment line, so I just want to ask if there's any public comment on this item. You can press *3 if you would like to make comment on item 2. Seeing no hand, then I will take your 2 motions as action, commissioners, and the minutes are approved. We can move on to item 3, the regulatory affairs report.
Good, thank you.
Good afternoon, commissioners, and I am pleased to offer an overview of the regulatory affairs report. I do want to just share with you that Daphne has moved on to a new role at a different organisation, so I'll be providing this report for the next couple of months, and then we are looking for a replacement for Daphne. There'll be hard shoes to fill, but we'll do our best. So we have 3 pending surveys, 2 for the skilled nursing facility here at Zsfg and our dialysis unit over in Building 100. We're overdue for all of those surveys, but we know that they're not a priority to the state right now, as they're really trying to close out many of their incident reports, and they've been very focused on COVID. We did have 1 completed survey, and that was our biannual laboratory accreditation survey. That was a year late. We were actually due for that survey in the summer of 2021, but we received that this year, and I'll go into more detail later in the report. We submitted 1 plan of correction, and that was secondary to a CMS complaint validation survey, and it was entirely focused on med staff bylaws and med staff processes around OPPE and whether we were following our bylaws for OPPE, and then around proctoring. And the medical staff came together and made a lot of changes to our proctoring and our OPPE processes, made some changes to the bylaws. The state accepted our plan of correction, and we're waiting for them to revisit us so they can see whether we have indeed done the things that we told them we were going to do. But there's a lot of kudos to Dr. Gelb and the Med Staff Office, Lisa Winston, and all of the other chiefs of service who worked really hard to get OPPE up to date. And a lot of work has been done around proctoring to make sure that we're meeting our 2-year deadline for proctoring for medical staff. We do have multiple open site visits, and that list seems to get longer, and we're hoping that the state are able to catch up at some point with all of those open cases. There was a question, I think, from Commissioner Green around a resident-to-resident altercation that happened in 4A on our skilled nursing facility. We had 6 new facility reported incidents. There was a COVID outbreak in 7B, one of our psychiatry units. There was a HAPI in the ICU. There was another outbreak notification in our ACE unit for our med-surg that focuses on an elderly population. And then 2 resident-to-resident allegations in 4A. One was a verbal threat by a resident to another resident that he would use a firearm. The resident was never in possession of a firearm in the hospital. There was some anger involved in that, and there was a lot of work done by the staff on 4A, the providers, and then additional resources were used to try and support that resident through his journey on 4A. And then there was also an allegation of some sexual misconduct and drug dealing that one resident made regarding other residents and staff. But we were able to ascertain that we didn't see any. We weren't able to substantiate it, and since the report was made, this resident seems to be having some really difficult times with their perception of what's happening around them. So we don't anticipate any big problems with the state from that, and this resident's getting the care that they need. And then lastly, there was a privacy breach where staff recorded a incident that occurred between San Francisco Sheriff Department and a member of the public who was in the plaza outside of the hospital. And we worked with those members of staff to make sure that we were able to retrieve those videos and that they weren't shared. We don't have any plan of correction monitoring because ALCC was scheduled for the same time that the Joint Commission were here for our lab survey. So we will have some more plan of correction data, monitoring data after we meet this week for ALCC. And then the last thing I want to share with you is the safer matrix for the Joint Commission survey for the laboratory. And we put the safer matrix in because we really wanted to demonstrate that all of the findings are in that bottom left-hand corner, which means they're of the lowest severity and the lowest scope. And then the letters and numbers that those pieces in the box refer to are on the last page of the report. So you'll see on that report an overview of the things that the Joint Commission found. What I will say is that we see this as an incredibly successful survey for our lab partners. They have these findings represent less than 1% of the of all of the standards and elements of performance that were assessed as part of the visit, and none of them were of a wide scope or a high risk. So we really see it as a great success. And the lab are working really hard on their internal pieces, and there was just two findings that were actually spread outside of the lab. One was around competency for blood gas testing and the required education for the individuals that do the proficiency testing for that. And that was corrected on site actually as we changed the process for that. And then the last piece is the documentation of critical values. And anecdotally, I can share with you, and I'm sure many of you who practice know that documentation, dotting the I and crossing the T, is often the devil in the detail. And it wasn't a widespread finding, but it nevertheless is something that nursing is working in collaboration with the lab to really try and figure out how we can get it right every time, as opposed to missing it on a very small amount of occasions. But of course, that's what the Joint Commission found, and that's a patient safety issue, and we take those things very seriously. I think that addresses the questions too that were addressed to me. But if there are any other questions or comments, I'd love to answer them for you.
Fine. Oh, thank you. It's a very thorough report again, and the matrix is interesting. Does the Joint Commission put that matrix together, or because that's a very neat way of doing things?
Yeah, that's the way the Joint Commission present an overview of their findings at every survey. So moving forward next year, we're expecting our triennial survey, and then we're also expecting our stroke and TBI surveys at the end of this year or the beginning of next. So you'll see those safer matrices come through after those surveys too.
Commissioners, is it okay if I check the public comment line for this item?
Yes, please.
Sure. Folks on the line, if you'd like to make comment on item 3, the regulatory affairs report, please press *3 now. Again, *3 if you'd like to make comment on number 3. All right, no hands, commissioners.
I only had one question, which under the survey summary, your first paragraph, you have a report pending, but this was a anticipated deficiencies from a May 9th to May 17th. What is that part of the laboratory also?
No, that was so when the surveyors came out to address the CMS complaint validation, they will provide us with findings in under 2 sets of regulations. So we've received the 2567 or the statement of deficiencies for the federal regulations, and they were all related to medical staff services. We will receive a separate statement of deficiencies related to Title 22 state deficiencies, and we've not received that yet. And again, you can see that there was some a very limited amount of findings that were really limited to either 1 or 2 staff members or 1 or 2 occasions. So we've not received that. We anticipate those findings. We've not received that statement of deficiencies yet, and as soon as we do, we'll communicate that to you. The plans of correction related to those findings are already mostly written and underway to address them. And in fact, all of the people with TB and fit testing and e-learning and HIPAA training, that's all complete and has been done. And we've also reviewed annual training for this year and annual TB and fit testing for this year to ensure that there are no other gaps, and we're fairly confident that we've managed to close all of those.
Very good. Commissioner Green, any other questions?
No, thank you for asking. I appreciated the responses from the questions I had submitted.
Okay. No, thank you once again. A very clear regulatory affairs, and we'll all continue to wait for the state to get through the large number that seems to be still pending. So, appreciate again the clarity of the report. Mark, can we go on to the next item?
Of course, item 4 is the Quality Core Measures Scorecard. And commissioners, I believe this is Ms. Safir's last presentation to you. So let's bid her adieu and celebrate all the amazing work. I hope that's okay to say, because you told me.
Yeah, thank you. I just want to first of all, thank you commissioners for all your engagement, your questions, and your support over the years. I have accepted a position down at Santa Clara Valley Medical Center, which is much closer to where I live. And I'll be leaving Zsfg, and this will be my last report. And it is really hard to leave, especially all the people here. And I hope to stay in touch. And I just, really want to thank you. I'm going to dive right in now into my core measure scorecard and the report. All right, so I'm going to first bring us to our prenatal measures, perinatal measures, and share that we saw a slight increase in cesarean section rates in our Q1 2022. And this rate, however, we don't believe it's to be statistically significant. We sample for this rate, so we look at just a portion of the mothers who deliver here and look at that rate, and so there can be some variability. And when we actually track our actual rate as well, and so when we compare to our actual rate, we're at 16%, which is below both our goal and the Vizient median. Vizient median is really all, Vizient is a consortium of different hospitals. Not all show the same characteristics of us, but that's the median, so about the 50th percentile of their members. We also saw a little increase in elective delivery prior to 39 weeks gestation. However, that was just one case, and it was clinically appropriate for that patient to do an elective delivery. However, they were not excluded from the measure. Our perinatal attending physicians have increased actually the frequency of their morbidity and mortality review from once a week. Now they're doing it twice a week, really, they're including discussion of prevention and mitigation for cesarean section cases, seeing that there's a slight rise going that they've observed. And we continue to meet targets with our exclusive breast milk feeding during hospital stay, that measure, and to monitor our unexpected complications in term newborns. I'll now go into the psychiatry measures. We're highlighting 3 here. One, psychiatry has met target for the last 3 quarters, 100% for patients discharged on multiple antipsychotic medications with appropriate justification. So I just wanted to take a moment and recognize that. We do continue to see high rates of seclusion and restraint use. And so working with psychiatry, I spoke with them and they shared the reason for the seclusion use is when they looked at Q1 data, really attributable to 4 patients with significant length of stay in seclusion. These patients had some similarities. They had paranoia, attempts to leave the unit, refusal of medications, which results in a need for a court order to mandate medications, assaultive behavior towards patients and staff, and mood disorder diagnosis. We also saw a pretty significant increase in restraint use, and a lot of that is actually attributable to a single patient that had 130 hours in restraint. This patient refused medications, and eventually they had to get a court order, as well as exhibited assaultive behavior to staff due to command auditory hallucinations. There are a number of measures that are implemented in real time to help take patients out of restraint and seclusion. A few are clinical nurse specialist assesses all patients within 24 hours of seclusion and restraint and consults with nursing staff. There's clinical pharmacist review as well, and one-on-one sensory treatments and coping skill development with an occupational therapist. And then all patients in seclusion and restraint are discussed at morning meetings and huddles, really emphasizing how to get those patients out of these interventions, seclusion and restraint. The final thing I'll review this year, I do this annually, is our electronic clinical quality measures. ECQMs are electronic clinical quality measures. They are clinical data elements that are transmitted directly from our electronic health record to the Joint Commission and Centers for Medicare and Medicaid Services. We report to both bodies, we report the same metrics. There is no ability for manual record review. We have taken significant steps in 2021 and continue in 2022 to validate these metrics, to align the metrics so they're actually reflecting our current workflow. So in calendar year 2021, we reported 2 quarters of, we selected 5 self-selected measures. The minimum was 4. And these will be publicly reported. There's also a benchmark from our vendor Medisol, and we've included that as well. And then for calendar year 2022, so we submit these files about 3 months after the close of the year. So we wouldn't expect the 2022 data to be submitted until about March, April 2023. And this is the first year in 2022 that they're mandating one metric. It is a safe use of opioids metric. So the team is currently working on validating that metric, and then we'll select 3 to 4 additional measures. You can choose more than the 4 minimum. And we plan definitely to submit the 2 VTE measures. We've made changes to Epic and our workflows to align this measure with our workflows and improve our compliance. And then we will likely report 1 to 2 of the stroke measures because those have already been fully validated. So let me take a minute and ask for questions.
May I check public comment?
Yes, let's check public comment while I try to match this to our slide here.
Sure. Folks on the line, if you'd like to make comment on the quality core measure scorecard, item 4, please press *3 now. Again, *3 to make comment on number 4. I don't see any hands, commissioners.
Thank you. I see what was wrong. It was just that you're scrolling through the slide. I mean, my slide is complete and you were scrolling through it because I thought we were missing one or two of the points that said.
Yeah, I was just trying to zoom in a little so people can see it. Mhm.
Well, you know, you've over these years, Leslie, you've actually put together a format that's made it very easy to understand, and really appreciate that. You've got designations that show which ones are star ratings, which ones are the quality program, um, and I'm hoping. Um, I think that's a great asset, probably to Santa Clara, and I'm really hoping that our next person will understand that those are really important things, that while we don't necessarily comment on it, it really allows us to understand the significance of each of these measures. So aside from that, I mean, obviously for these years, you've really brought us a long ways towards the scorecards that we are now appreciating. And uh, I'm thinking that certainly all of us who have been working with you wish you well in your next venture. It's better to be closer to home, but we're very sorry to be losing you. So uh, thank you.
Dr. Chow. Mhm.
Um, on the measures that are electronic, and we've got some dashes in between the numbers. So, are they significant, or do we only measure every half year? Or
Yeah, that's a great question. So the dashes are actually, we submit to CMS, actually in Joint Commission, we have to choose 2 quarters. So those represent the 2 quarters of data that we submitted, and we chose our best performing 2 quarters to submit that data. We do have the measurement for every quarter, but that was actually what was submitted. And then for 2022, we will, we have to submit at least 3 quarters of data. So you'll see more data for 2022, and we're actually working on our EPIC reports now, so we can see in more closer to real time how we're performing on these. So maybe eventually we'll be able to see more frequent data on our ECQMs, leveraging the EPIC reporting tools.
so, what are the consequences? Or I guess first, uh, the benchmark, which seems very high, uh, is uh, uh, I guess uh, has some sort of significance. I mean, do we gain points or lose points if we don't reach the bench?
Yeah, that's a great question. And right now, all these measures are paid for reporting, and so they're just there to show us kind of where good is and where what we want to strive towards. However, these are not paid for performance at this time. And I did some research just to see if I could update myself if anything has changed. And I don't think there's not anything. Eventually, this may factor into some of the pay for performance programs and the star rating, but nothing to that effect has been published yet by CMS. But I would expect potentially in the future, we may see this incorporated into some of those programs. This is the first year, I believe, they're starting to share that data publicly.
So, is there any comparison to our other hospitals that may be within, just like there are with some of the others, either the university hospitals or what?
Not yet. I think for some of that data, it's new and it's just, they should be publicly reporting it for this year. I will see what manner they publicly, CMS chooses to publicly report it. But my assumption is we'll be seeing more benchmarks and more comparison. But my assumption is we'll be seeing more benchmarks and more comparisons over time.
Commissioner Green, sorry, I should have asked you first. I just had these questions in mind. I didn't want to lose them.
Absolutely. Well, first, Leslie, you've been fantastic. I mean, coming into this joint conference committee, having no idea what any of the abbreviations meant. And I have to say, others, Susan Christian in particular, who's not even a physician, heard one of your, I actually sent her one of your presentations, and she felt like she really understood, thanks to the way you categorize things. And you've made this so easy to understand. And then, you know, with that understanding, we can ask meaningful questions and really get a feel for what's going on. And I'm sure that's helped everyone on the staff kind of reach their goals, as well as, you know, it's so well defined what you know we're trying to achieve here. So we are really going to miss you. And I have 2 spare bedrooms, by the way, just in case you want to change your mind. But you know, you've been great. I wanted to understand a little bit better. So, what you were saying about the quality incentive components, were you just talking about the electronic measures, because the OB ones, have the quality incentive program and then the CMS star listed. So are those
Yeah. So I do not see actually in the near future, at least not for the quality incentive program, is going to be sticking with actually the quality incentive program there are different mechanisms that you can use to report. You can do sampling, you can do some chart abstraction, you can use, so sometimes they leverage ECQMs, but the PCO2 and the PCO5, those are actually, it gets a little, those are reported through a vendor, the maternal data center who we work with. And then through that vendor, the cases and the information that we upload to them, that's how that data actually goes to the quality incentive program. So QIP is not getting that sampled rate. They're getting more the full rate through the maternal data center. That's the flow of data to them. These ECQMs at the bottom may potentially go into maybe some of the CMS, so like value-based value-based purchasing program potentially in the future, or star rating, but I'm not sure about that. QIP, these metrics, they are going to keep reporting things in the mechanisms they are. There are a few QIP measures where you can leverage electronic clinical reporting, some of the metrics that have been built for that. But at this point, Zsfg is not, we're doing that for one of the stroke measures.
Great. Well, thank you for the clarification. It might be really interesting, especially with what you mentioned about the disparity in the cesarean rate, to know what's real and what what's on this. And I could wax eloquent about why many of these OB metrics are incomplete, because you can clock C-section rates, but you also have to clock complications of not doing sections. And unfortunately, I think this is unfortunately a superficial way of looking at the totality of obstetrics, which unfortunately can cause some decision making that may not be the best, as we all lust after low cesarean rates, no matter what the complications of avoiding a cesarean might be. But I know just from our own statistics, and I can speak to the yours compared to my hospital, that they are far superior to the numbers in my hospital, at least on the OB side. So that's great. And thank you again for making all of this so understandable.
Thank you.
Can I just say that our loss is Santa Clara Valley's gain, but Leslie will be sorely missed in the quality management department. We've been peers and we've supervised one another, and my relationship with her has been an integral part of my success here. So I'm so pleased for Leslie that she has an opportunity that she's wanting to go to, but it is bittersweet.
Yeah, I also want to chime in, Leslie. I've learned so much from you, and I've so enjoyed working with you in the various roles you've had at the hospital. Your dedication to, really helping people understand these data, your dedication to making sure that we are the best we can be as a hospital and that all of our team are supported, I've appreciated so much. And I agree, Santa Clara they don't know yet how lucky they are, but we do. And we're just really grateful for the time that you've spent here. So thank you.
Well, thank you again very much, and we're going to miss being able to receive not only the scorecard, but I noticed and should comment on the fact that the written explanations are really always good. And so again, I don't envy the Adrian for having to help search and the hospital to help search for a replacement, but I'm sure he's going to carry on right now until we do find somebody who's going to be just as competent. Thank you. So we wish you well. Thank you very much. Shall we go on to our next item if there are no other comments? I mean, we appreciate this report, and the explanations as to why we're out of line in terms of especially the continued problems with restraints and seclusions and the need for us to. That was right. I wonder, Leslie, if you excluded the outliers, would you then fit and match more what they were expecting in our norm?
Yeah, I would say that we've never looked at it that way. And I think that we've always had the different, organization compared to some of the others, we tend to use higher levels of seclusion and restraint based on our patient population as well as the physical layout. And so we haven't done it in that way, but that could be something to consider for the future. If we take out, the significant outliers and their days, does it seem more in line? That's something definitely to consider.
Yeah, I think that would be nice because then we'd see if the norm actually, aside from those outliers, is also being followed, or where we may have areas for improvement also. Thank you. Mark, let's go on to our next item, please.
Sure. Item 5 is the CEO and Emergency Department newsletter item. Dr. Ehrlich.
Good afternoon, Commissioners. It's always a pleasure. My report, of course, is before you. I wanted to just say a couple of things in preface to the report. Every month, there's a kind of a theme, I think, to what's happening at the medical center and in the department. And right now, it's really pretty stunning, all of the things we're dealing with. And I would say it's kind of a trifecta at this point. We have COVID still with us. That has not gone away. We have now a second global health emergency, monkeypox, which has been front and center in our lives. And then last but not least, I think you know that our organization is very much involved in helping Laguna Honda with its recertification efforts. So there's just a tremendous amount of work that's going on here, in addition to the day-to-day work that we perform as a hospital. And I want to express my gratitude to the leaders who are here and the leaders who aren't, for their incredible dedication and hard work and resilience as we navigate this very challenging time that we're in. In better news, I also wanted to congratulate Ayanna Johnson. Ayanna, our Chief Experience Officer, was recognized by Becker's Healthcare, which you know is a national prominent healthcare publication. They recognized 52 outstanding Chief Experience Officers from around the country, and Ayanna was one of them. So it's really a nice recognition and very, very, very well deserved. Going on to the report that's in front of you, I wanted to pause a bit on monkeypox. So as you know, monkeypox was declared a global health emergency on July 23rd. That's since this report has been written. And the United States is a big part of that global health emergency. California is a central focus, and then within California, San Francisco is a major hotspot. That's really demonstrated by the fact that 434 cases are in California, 215 now are in San Francisco most recently. The other thing, we always rise to these occasions, and we have now become a really important hub for vaccinations, and pretty unprecedented in the community and even around the country for the number of vaccines that we're providing, and we're providing them as quickly as we can get them. So, for example, when this report was written, we had administered 1,165 vaccines. Well, as of yesterday, which is the last time we were administering vaccines, we had almost double that number to 3,000, well, more than double to 3,127 vaccines. And as soon as we get more, we will be back at it again. So I feel very proud of the role that we're playing in this monkeypox pandemic. There's a piece here on the clinical laboratory because Adrian talked about it. I think I won't go into detail more other than to really thank the laboratory and the quality team who supported this survey, which came after a year of waiting and was, as these surveys are, very complete. I will pause there on the narrative part of my report and ask if there are any questions or clarifications you would like before I go into the data.
And commissioners, before you might jump in, I also want to reiterate, I sent Dr. Ehrlich an email, but I want to just testify. I stood in line for the monkeypox vaccine at 5:30 in the morning and received it around 8:15 last week, and was so pleased at the efficiency. I mean, the waiting wasn't great, but I was appreciative that you all were there. I tried to access it through my own primary care provider. They didn't know what I was talking about and had no access, I had nothing. So I just want to, again, kudos to the operation. I saw folks out there, the staff were out there at 6 in the morning, well beyond when the clinic was supposed to be open. And there was incredible caring and well thought out processes. So, not surprising, but again, thank you, a personal thank you.
Thank you, Mark.
Thank you. I guess on the monkeypox, when you do get more vaccine, how do people know that? Do you then put it onto the website and that you then set up new dates, or what will happen?
Yeah, so this is part of what the Department of Public Health's and the group that's focused on monkeypox now. This is part of what they are trying to do, is to ensure that that the accurate and timely data is out in the community, and they'll do that, not just on the website, but I think even more importantly on social media, just to make sure that I mean, that's more likely the way that we put information out into the community. So I think that's primarily the way we do it, and it really has to be done that way because we don't know until the day it comes really when we're going to get vaccine and how much is available. So I imagine that will change as time goes on, but right now that's the circumstance we're in.
And do we have any sense when the next vaccines are due?
I thought we were going to hear about something today, and as far as I know, maybe some came in, while we've been meeting, but it really is a day-to-day, hour-to-hour thing.
Okay, let's go on to the data if Commissioner Green doesn't have any further questions at the moment on the text, and then we could ask for public comment and then go back to reviewing the report.
I just have one quick question, which is, given the uncertainty of receiving these vaccine doses combined with the staff that's been out with COVID, how are you managing to staff the actual vaccine clinics? That must be somewhat stressful or difficult because you almost have to gather a staff with very little notice.
Yeah. Well, we do have where these vaccines are being administered is in the same clinic where we're administering COVID vaccines. So we do have some staff and resource who are very accustomed to providing vaccines. Heretofore, it's been COVID, but now they're getting really good at doing the Jynneos vaccines. So we're using, and this is the urgent care clinic. That has been just so fabulous in organizing this response. So we're really using the COVID resource we have as flexibly as we can to address monkeypox.
Great, thank you.
Thank you.
Okay.
All right, so Dr. Ehrlich, you want to go on to the data?
Yes, I'd be happy to. So the data starts as always with our you can see the 6 surges, there are 5 surges, even though we know there have been 6 really. And the COVID positive patients at Zsfg, we can see it's starting to come down. It's been fairly stable. Today, I believe we had 17 COVID positive patients in the hospital, none in the ICU, thankfully. So it's been stable-ish, coming down, which is good. It's hard to know where we're going with COVID at this point, I have to say, because the testing data we know that's reported is really not accurate because of the vast number of tests that are being done at home now. Data from other countries imply that we may see more hospitalizations upcoming, and certainly we would expect to see them in the winter. But right now we're holding steady. As far as the emergency department, I will pause on this. I know there were some questions about our leave without being seen rate and our diversion rate, which remains stubbornly high. The primary root cause for these high rates, higher than we would like, is our continued challenges with staffing. I know that Karen will report on that in the HR report. We're working with HR to staff positions in the ED as much as we can. We still have a high vacancy rate. We still have, staff who are intermittently going out with COVID. So that just continues to be a challenge. I see a report on staffing from the ED every single day, and also the progress we're making with staffing. It is a very slow improvement, but that's kind of where we are right now. We're starting a new training program. We just finished a training program. We're bringing in registry. We just are starting 2 new experienced nurses. So we are making progress. It's just quite slow in this environment. The happy news on this front is that the urgent care clinic continues to really help quite a bit in this quest to see patients who present to the ED as well as urgent care. So we continue to see an increase in their average daily encounters. We continue to see increases in the transfers of the lower level, level 4 and 5 patients from urgent care from the ED to urgent care, and a pretty stable number of transfers going back the other way. So that's really helping quite a bit as we manage that patient flow. In terms of the psych emergency, I just want to mention, if you look at the data on PES encounters, that's pretty stable. And as you know, all patients headed to PES now still have to start in the ED and be evaluated before they go to PES. There is going to be a Board of Supervisors hearing this Thursday morning about conditions in PES and behavioral health services that help mitigate patients going to PES as well. There's quite a long list of folks who will be testifying there, including Dr. Leary from PES, Hillary Cunnins from BHS, the fire department, police. So just so that you're aware, there'll be a hearing about PES and behavioral health in the community generally. I think the other thing I want to focus on is our lower level of care. You'll notice that our med-surg lower level of care average daily census is creeping up a bit. I want to really congratulate our Department of Care Coordination for their amazing handling of our circumstance right now. As you can imagine, with the big push to move patients out of Laguna Honda from the state and federal governments, we have some competition in moving patients out of our med-surg unit. We're working very collaboratively with Laguna Honda. There's a weekly meeting that I attend and Dr. Horton attends with the 2 Department of Care Coordination staffs, just to make sure that we're managing the flow as best we can. Those teams meet every day. So we're keeping an eye on it. It is the census is going up, but it's been manageable so far, which I'm really grateful for, and I commend the team for managing as well as they can. The only other thing to say is that we're starting to see with our occupational health data, and now I'm looking at page 20, we're starting to see that very high level of staff who have been out with COVID coming down. I believe the total number today was 150, which is down from the high that we've had previously. So that is really good news. And our occupational health team has been fabulous in managing that this latest surge that we have that is now getting a little bit better. With that, I will stop talking and see what questions you have or what I can further clarify for you.
Commissioners, may I check the public comment line?
Yes, please.
Folks on the line, if you'd like to make comment on item 5, the CEO report, please let us know by pressing *3. *3. No hands, commissioners.
Okay, Commissioner Green.
Well, no, Dr. Ehrlich really clarified the 2 questions I had, which were really about the diversion and the left without being seen. And it was so well written in the email. I really appreciate it. So I don't have any questions.
Okay.
Okay, on page 14 had 2 graphs, and I was wondering on the maternal child health as it goes up and down, and you've now opened to private patients. Um, is there a way to understand if the private patient load is going up or down, or it is our health systems that's going up and down, or is it that the private patient is so small that it wouldn't be something worthwhile in trying to understand?
Um, I would say that the pattern of the census here is more reflective of the overall baby boom in the community than it is, a sudden influx of private patients. I know we've had a few, but I don't think that that's a primary influencer of what's happening with the census. It's more that just that births are going up generally in San Francisco. Unfortunately, we're seeing more of them. At ZSFG, which is good and what we'd like to see.
Okay, so on the next slide, so right now we're thinking that's just sort of a general thing, and that the number that drop, for example, is not reflective of privates coming or going, and
I don't think so. I mean, I think, what we generally see is the trend going up. I don't really know what the meaning of the 27 is in June, versus the 34 in April. I think we need to see the trending going on for a longer period of time to know.
no, that's fine. I think just keep that in mind in case it looks like there would be something significant for us to be aware of. Um, on the following slide, then I realized that the acute psych daily census is uh, combined with the non-acute, or is that only the acute?
Oh, it's all, this is the total census. I mean, it says acute psychiatry because that's the unit. These units are licensed as acute units, but they include patients who are actually acute and patients who are waiting to be transferred elsewhere.
So I think at one time, and maybe that's way in the distant past, but now I'm thinking maybe we should take another look at that in terms of being able on the graph to represent what actually was acute versus the administrative and the border type people.
Sure. I mean, what I can say is that it's, maybe about 10 a day who are actually acute. But we could look at including that in the graph. That wouldn't be hard to do. We see those data every day.
Okay, yeah, I think that would be helpful in looking at whether or not the trend is stable, or we're not making any headway, or we were making headway in terms of trying to move people. And as recognizing it's certainly a challenge, continues to be a challenge all these years. So,
Yes, indeed.
um, and all the areas that you highlighted, I marked and thought that was good. My last question was on page 21 with the violence report.
Mhm.
And I was struck by the fact that it looked like the behavioral health unit only had one incident, or is that sort of supposed to be the good behavior unit, and we shouldn't see that because we certainly were aware of the issues in psychiatry, but
Yeah. I think, in general, if you look over time, the the largest number of incidents come from PES and the emergency department. And so the fact that there's one in June, I don't think that is, I think it's just chance. I invite Adrian to say more about that, but you know, we look at these data very closely, and I'm not sure why in this month there were so few there.
I'm just looking at the more in-depth workplace violence report to see where that event actually occurred, because I don't want to misspeak. I think that
Yeah, that's a good point. Is that PES or is that the BHC?
I think it's the BHC, but I'm just looking at the data to confirm that, because I don't want to speak out of turn and give incorrect information, if that makes sense.
Yeah. Yeah, I think it's a good point that we need to be careful about the way these are labeled, just to make
Yeah.
sure that the labels reflect the terms that we typically use for these places. Thank you for checking, but it is really true, Dr. Chow, that the largest number of incidents happen in PES in the emergency department.
So that event was actually on the Mental Health Rehabilitation Center, so it was in the BHC. So it's doesn't reflect anything happening in psychiatry. And you know, as Zsfg now oversees the BHC, even though it's not on our license, we want to make sure that we are inclusive, especially with workplace violence, so that one of the big things that Andrea Turner and I are working towards is making sure that all staff on the campus, whether it's in a licensed area of the hospital or not, feel represented in the data that we present, and so we understand what's happening throughout the whole of the campus. So that event was actually in the Merck across in BHC. We don't see many events over there, but we do want to track them.
So I'm wondering, as we are looking, this is sort of my my month, I guess, of looking for trends. Uh, well, we're doing total events by month, and then we break them out. We're not able to actually follow the trend on that, even though we're aware that most of these are in emergency and psych. Wonder if there's a way that we could then maybe using the total event bar to break that into the big blocks that we have here, so that we could either track how many are in the psych unit and whether that remains pretty stable as versus the emergency. Um, I, not having Leslie here, I'm not sure.
I think we can struggle through without Leslie, but I think
Yes.
I think what you're asking for is to see, we can see the total events by month trended for the entire organization, but what you're asking for, Dr. Chow, I believe, is how do those trends over time look in the places, especially where we tend to have more of these incidents?
Yes.
Okay. Yeah, we can definitely work on that.
Yeah, we can do that.
Okay. Thank you very much. Those are my only questions, and I appreciate the emergency department update and the colors, and the work that they continue to be doing. So, Mark, I was just going to ask you. They are talking about a compliance program that has a rather complex set of non-intuitive entry points. Is that a program we're all going to have to take, or it's only in the ER?
Oh, are you asking me?
Yes.
I'm unfamiliar with that. I can check on it and get back to you. I've heard nothing from anyone, so my assumption would be no, but I will check and certainly get back to all of you.
Okay, because if we were to do it, this sounds like really a complex set of instructions, which is somewhat counterintuitive. For example, it says, do not click my learning, and you have to go through 2 or 3 more steps before you get to click my learning. So, I mean, if we're all having to go through this, then I think maybe this is a good cheat sheet.
I will keep you posted. Thanks for the question.
Okay.
And okay to move on to the next item?
Yes, please.
Great. Thank you, Dr. Ehrlich and Adrian. Item 6 is the ZSFG hiring and vacancy report. Ms. Hill.
Hi, good afternoon, commissioners. I would like to first point out to Commissioner Chow, I want to make sure the timeline we provided on the status of vacancies over 10% is what you were looking for. It shows the established timeline.
Yes, that's very helpful to know
Okay.
that certain types of categories we're expecting either quicker or longer periods of time. So I really appreciate that. I was going to mention that, and thank you for bringing it up that was added.
Okay, great. Okay, so next you have my report in front of you. There's a couple of highlighted items that I want to highlight. I'm sorry, it would be items number 6 and 7. Well, actually 5, 6, and 7. So we have, just to add on to Dr. Ehrlich's report about the challenges in ED, we do have an upcoming training class for ED, August 8th, and that will be 9 hires that will be coming in into that training class for ED. So hopefully that will be helpful and provide some relief. We know it's going to be a couple of months before that training is complete, but that's 9 that are coming in the next couple of weeks. And then the next class is scheduled for December 2022. As well as, the ICU, they had a class that started a couple of weeks ago, July 9th, and that was 5 that was hired into that class. And the next class is scheduled for November 2022. So we're hoping to attract more training, not only attract, but fill more training positions as well over the next couple of months to build that pipeline, up into our experienced nurses, because we are having challenges, not only having our experienced nurses applying, but them accepting our jobs. So, we are trying to balance the two while we're looking to continue to hire experience, but as well as focusing more energy on the students and trying to get our training class increased and build a pipeline for our nurses. And so jumping into number 7 is that we're looking to host another RN event mid-September. And that will be to, touch the students that recently graduated, that training class. Sorry, not the training class, but those students, those medical students that just recently graduated, and to try to encourage them to apply and extend some offers during that RN event, as well as the applicant pools, the experienced applicant pools that are currently in our, the applicants that are currently in our applicant pool, and encourage them to accept offers. We have been extending offers over the past couple of weeks, and we either will get the offers accepted and then they drop out during onboarding, or they're just declining. And so we have our recruiters and our RN analysts kind of touching these candidates that are in the applicant pool, because they're applying for our jobs, but they're just not accepting offers. And for ED, especially ED and critical care, the hiring managers have touched each one of the candidates and extended offers, and they have taken jobs elsewhere. So we really want to look at the root cause of of why they're applying, but then decide not to take an offer. And it could be the shifts. It could be the night shifts. Not exactly sure, but we're working on that data to to find out what's happening there. And in addition to just the challenges with just the applicant pools, we are facing some challenges with the limited number of medical examinations, which is kind of delay our start work dates. And that could be part of the problem as well. Candidates are dropping out because our onboarding is taking a while. And so we are working with our occupational health partners and with providing them resources to open up more available slots. But the hiring has just increased over the department. It's not just at Zuckerberg, but in our ambulatory care. We got the push at Laguna now that we're just we're hiring up and making more offers. So a lot of those offers and those requests to hires are now stuck in the pipeline trying to get those onboarded, and knowing that our occupational health is not just for Department of Public Health, right? It's for the entire city. So that's one of our challenges as well, but we're working through those challenges. So those were the three highlighted items that I wanted to report out and focus on for this month's report. And so I'll stop there and to see if you have any questions.
Mark, let's ask for public comment.
Sure, there's one person on the line at this point. Person on the line, if you'd like to make comment on item 6, the hiring and vacancy report, please press *3. Again, press *3 so we can recognize you if you have a question or comment. No hand, commissioners?
Thank you. I wonder if Commissioner Green has comments, and also any of our staff members here at the meeting who may want to chime in also, either in their department or with ideas.
I guess I had some questions. First of all, I know how hard you're trying, and I know how incredibly difficult this is. I know in my own institution, you've done better actually than where I work in med surg and a few other areas here. So I know you're doing your darndest, and it's just hugely challenging in the Bay Area in general. Um, and wonderful that you're doing these classes. I think that's terrific. Um, can you elaborate on the emergency declaration ending July 8th and more on what that means in terms of the of hiring and uh, kind of better understanding why this what can be done to really increase the speed with which the medical component of hiring is completed?
Yes, so the mayor's emergency declaration ended on July 8th at 11:59 p.m. And that emergency declaration allowed us to bypass the exam component of the announcements, right? And so for the RNs, what that meant is that when the RN applied, we didn't have to wait for, list adoption, for them to go through a list adoption, the posting, all those extra days, right? They apply, they get qualified, and then we can just pass that applicant pool over to the hiring manager. So what that means is that for all the positions going forward after July 8th, 11:59, actually July 9th, midnight, those new positions now have to go through that whole exam process, right? Which, of course, those extra steps. But for all the positions that we currently have, what we did was before that deadline is that we just pretty much, they had given us a blanket approval for all of our positions, but we didn't provide them position numbers. So what we did was just provided them all the vacancies that we had in the system on July 8th. And so that allowed us for every approved position to fill under the emergency declaration, but anything new after that has to go through the old process. So we still have the flexibility to do the hiring the way we're doing it now. Applicants apply, and then once they're qualified, we hand them off to the hiring manager to make selections. The hiring managers, to their credit, has been, wonderful, receiving the applicant pools and just, actually just going down the list, extending offers because they've already been vetted and deemed to meet the qualifications, right? And they've been doing their due diligence, making offers to everyone in that available pool and just not getting the response that we expect. So that's just kind of been a challenge there.
Well, thank you for clarifying. So in other words, even if there are positions that 3 months from now aren't filled, you can fill them in the same because they exist pre
Yes.
ending of the declaration. Do you have any projection about how many positions will open up post July 9th that are going to mean a lot more? I mean, did you really kind of fill your tank here? Or are there going to be more positions down the road? I mean, was it anticipatory? Or are you going to really be facing, these roadblocks, which we talked about a few years ago, how frustrating they were and how many employees you were losing as a consequence of these delays? When do you think that'll hit again?
Well, I feel like the challenge, well, one, we have new positions that we received in the budget, right? So we have those new positions that will not be under the emergency declaration. So that's around 39, 40 positions that will not be under this declaration, as well as the staff turnover. So that, one is the retention that we have to focus on. If we can slow down the rate that people are leaving, that will, allow us to hire, or focus on those vacancies under the emergency declaration and not have a large number of vacancies that are not under the emergency declaration. So we do know we have the 40 new positions, right? But every month we have to, prepare and anticipate for turnover. And we just don't know what those numbers are looking like. I mean, for last month, I believe it was just 5. We had, let me just make sure that number. We had a total of 5 RNs that left in the month of June, right? So if we, of course we don't want to lose any, right? But if we can keep those numbers to less than 10 a month, then, we will be okay. If we can keep it less than 10 and hire, triple that, then, it'll feel like we have some movement, right? So we hired, we had 20, let me see, we had 12 new hires for the month of June, but we had 5 RNs that separated. So we only netted 7. So, we just have to do a little bit more hiring in the month, right? Push on the hiring and getting those offers in, and then, focus on the retention and try to slow down the number of separations coming in.
Well, thank you again this is hard work, really hard work, and we're really appreciative of all your efforts.
Thank you, Commissioner Green.
So I was looking at your vacancy rate trend and that the slide that you had, which actually is not good because the 10.5, well, not quite 10.5, 10.2 and 10 is much higher than over the last 2 years that we've had, right? And
Yeah.
I'm hoping that we're not going to get back into the situation we had before. I thought that we were working with the city, and the city was working to see if it could actually learn something from the emergency process in order to be able to, get workers. And we know there's apparently a nationwide shortage of workers anywhere. I think Commissioner Green has noted that certainly in the Bay Area, in the medical community, the hospital communities, they have had this challenge. And so I commend you for trying to, tease out where the problems are. If you've offered these to candidates, what reasons that you feel the candidates aren't. But after having found that, then the question is whether or not we're going to be able to really move the agenda to
Right.
overcome those. So, but of course, it'd be good to know how we're going to find those answers. But are we still working with the city process, either in HR and all, to really look at continuous streamline? Obviously, the medical exams, that's our deal. Right? And well, it's the whole city, because you said the whole city goes through that process. But that should be one that should be, able, not tied up with all these exams and unions and whatnot, to try to break that time period that it takes to get a medical exam. I mean, that's just terrible if people are waiting for the medical exam and so they go elsewhere. But what do you think are the opportunities that the city is now looking at with the emergency ended to learn to help expedite hiring?
Well, I know I won't say anything specific just to RN, but as a department as a whole, I mean, sorry, not the department, but the city as a whole, one of the policy changes that the city has made under this emergency declaration is that the city has hired, probably hundreds, probably in the thousands of temporary employees in the category 18, which is the project positions, right? They're not permanent employees during this pandemic. And when the city hired all of these temporary employees under the pandemic, they literally exceeded the charter limit, right? And so in order to address the pandemic. However, now that we're post-pandemic, even though we're there, but we're not in the state that we were 2 years ago, they're now looking at, thousands of employees that have exceeded the charter limit. And if they separated all of these employees, it would just, disable the city, right? So one of the policy changes that they made was to have the departments to look at all of the category 18s, those temporary employees that were hired for over a year, and to look at transitioning those into permanent positions, into permanent employees. But that didn't impact our RNs. I mean, because that's not how we hire our RNs. Our RNs don't come in as temporary employees. They come in permanently. So while that may help us some in our non-RN, our non-clinical positions, it doesn't really help us with the RNs, right? So to answer your question regarding the RNs, we need to do the work to look at what are the reasons that we have the high turnovers, right? Where are the challenges? So we are able to present that to our stakeholders, city, with the city, with DHR and all our other stakeholders, the unions, to see how we can look at either streamlining our process or looking at other ways of allowing or look at other ways where we can have our applicant pool accept our positions, right? Because I feel like, the schedules of which we can control, some of the things which we can control, which is like our scheduling, how can we work with our stakeholders within a department to look at other options than just night shift? What other flexibilities do we have? So we really have to really find the reasons of why people are declining our positions and see where we can create flexibility within a department, and then the ones that the reasons that are not within our control, how can we work with our stakeholders, our external stakeholders, to remove barriers. But I just feel like this is a ongoing issue that we've had over the years. I think it's just gotten worse during the pandemic because now it's just the medical field is now just not it's not a career of choice anymore. People that were very passionate about, working in the medical field has, that passion has sailed, right? They're just now, just looking at other career, career choices. But, the question that I would have is that, we have applicant pools that are still large, right? And if they're applying for our positions, it's just baffling of why they're not, accepting our positions, or the offers that are being made when they're actually applying. So that work that we'll be doing over the next, couple of months will allow us to really understand, where it is that we need to make some adjustments. I'm hoping that I'll be able to provide, more detailed information by next month. I do have our RN analysts working on the critical care pool because we have probably close to 50 applicants in the critical care pool, but we have, like 7 or 8 vacancies in the critical care right now, but we have 41 qualified applicants, but no one is accepting a position. So we're curious to know why. And so they're working on that data now. And so I'm hoping to be able to provide an update on what we found, over the next month. So over the next 2 months, hopefully, but I'll be able to provide some update next month, and then the following month thereafter, and with some plan of, some solution or a plan of action of how we will address it.
Well, you answered my last question was to ask for a timeline, and we can expect to hear, considering that we've had a number of staff who are under the COVID occupational leave, and these vacancies that, as Dr. Early pointed out, that has impacted obviously even the ability to care for people within the ER and all. So we don't want to get back into a situation several years ago where not only did we know there were huge vacancies, but we hadn't done anything about them. So appreciate that you'll be bringing a follow-up at the coming meeting. Thank you.
And okay to move on, Commissioner Chow?
Well, let me see if any of the staff, any of our department heads or anybody want to add to this, because this really does affect all of them. Dr. Ehrlich, any further comments about this? And I'm only dwelling on the personnel because I remember in the past this has been a very great issue. We worked very hard to get through the hiring problem, and it's beginning to kind of show up again, right, in even this simple graph.
Yeah, I mean, I just want to say that I really appreciate the partnership with HR to bring people into our organization. It's true that, people think differently about careers in healthcare than they did before the pandemic, and that sort of adds to some of the barriers we need to overcome. Our city processes are challenging, but I think it takes a partnership between HR and management to figure out how to overcome that and bring people into work, because this is still a great place to work. And we want to give people the opportunity to come in and experience that and take care of our patients.
Okay, thank you. We'll look forward to a progress report in the coming month. Thank you. Yes, let's go on, Mark, to the next item, please.
Sure. Item 7 is the medical staff report, and Dr. Horton is presenting today.
I turned on my video and camera, I believe.
Yes.
Nice to see you. I'm wearing a different hat tonight. I'm covering Lisa as the Chief of Staff at Zsfg.
Dr. Horton, you're still not on camera, just for you to know.
Oh, I'm not? All right.
You were a brief moment.
Oh, wait, is that better?
There you are.
Okay, here I am. Great. So I have the before you should have the Chief of Staff action items and report. We didn't have a service report, but we have several updates. One update is that we have a new acting ZSFG OB-GYN service chief that we would like to inform you about. And I'm trying to remember if you have to vote on this. But Rebecca Jackson is going to be the department chair. She's the acting department chair right now at UCSF. And so one of our longstanding and really wonderful gems of a faculty member, Jody Steinauer, has agreed to be the acting service chief for OB-GYN at ZSFG. Dr. Steinauer has a really long dedication to the hospital, as well as to the training mission of the hospital. Is a major leader nationally, actually, in reproductive rights, and everyone was really thrilled that she agreed to step into this acting role. We don't always, when we have somebody who's we don't always have to vote when people are covering the role of service chief. But the reason that we did vote at MEC in this situation is because we anticipate that this acting role will be longer than 3 months, and at 3 months we are supposed to vote to approve of this. So in anticipation of this, we went ahead and voted to approve Dr. Steinauer as the acting chief of OB-GYN at ZSFG. Any questions about that update?
And actually, to clarify, it is on the action list, Dr. Horton, so it is something that the commissioners...
Okay, sorry, I get a little rusty, Mark. So I do believe that we do need to vote on it then. But I'm happy to take any questions now about what this looks like. This does mean that Dr. Steinauer will be joining us in Med Exec committee as well.
Okay, let's see. Are we going to act on this? Is that right?
Yeah, I'm sorry, Dr. Chow. I should have said at the outset that, or should have remembered that Lisa passed on to me that we do need to actually ask for your vote of approval in this as well, since it's on the action report and since this will be a longer than 90-day roll. So MEC has already voted to approve of this, and now it comes to you as the governing body to vote whether you would like to approve as well.
Okay, so I think the question here would be whether we want the entire report and then go into the action items, or do we want to take this up first and then go into the others? Mark, what would be preferable, because then we need public comment also.
Right. So in general, you all usually take all the action items together. So my 2 cents would be, well, why don't you go ahead and listen to everything else and discuss all the items, and then go back, take public comment, then go back and vote on everything as a whole.
Okay.
Good.
Thank you, and thank you for reminding me of the protocol, Mark. All right. So the other items that that we addressed in MEC over the past month are we needed to update the rules and regulations for otolaryngology. There is a summary of changes that you'll see as well, but a brief update about changes in general in the otolaryngology department is that we have unfortunately had a departure of our chief of service, and we have an acting chief of service in otolaryngology. Luckily, we were able to get input of both of these individuals into the updated rules and regulations, and Lisa Winston herself completed the updates to the rules and regulations. There's a number of changes, a lot of which are just deal with the language and appropriate terminology at this point, and some of which more accurately describe current services. That was another item that we addressed. And then we also reviewed a new standardized procedure for Botox in the for a standardized procedure for nurse practitioners and physician's assistants to administer Botox in the case of chronic migraines, for the relief of chronic migraines. This is a procedure that our faculty are trained in and do perform as a privilege in the neurology service, and we would like to, with appropriate proctoring and oversight and approvals, like to introduce this as an SP in the in that clinic as well, with the supervision of the faculty who have that privilege. And then finally, we've addressed several other things in MEC this month. We have, as you know, a revision of our OPPE process. And so Dr. Gelb congratulated all of our services on substantially changing their OPPE process and in reaching high completion rates for OPPE, as well as thanked the EPIC team for all the hard work, and the our data teams in general for all the hard work in bringing the OPPE process into more of the modern era. Finally, we had some revisions in our credentials committee that were reported out on. This sounds it's a little wordsmithy, but we actually got feedback that we needed to change the language on some of our the way we listed privileges. The language we included was too broad, so that it might be interpreted that many more procedures were included in the approvals, and they requested that the language be more narrowly described to refer to just the privilege that was explicitly being mentioned in the privilege itself. And so we did some revision to our the privileges that use that broader language. And I'm happy to take questions about those particular items that I'm reporting, or anything else that you would like to ask about the MEC activities in the past month.
Thanks, Dr. Horton. Shall we look for public comment?
Yes, sir. So person on the line, if you'd like to make comment on item 7, the medical staff report, this is the time to do that by pressing *3. Again, *3. I don't see a hand, commissioners.
Okay, Commissioner Green, any questions?
Yeah, I just had well, first of all, congratulations on the depth of skill you have in the OBGYN department there. It sounds incredible. In terms of this privilege delineation, I think we're looking at surgery and the family and community and the orthopedics, but I know there are other services as well. Is this something that you'll have to look at for all your procedural service lines and adjust, or is this unique to these service lines?
This is what I'm going to double back to assure this, but this is what I believe based on my conversation with Dr. Galb and Dr. Winston, that we looked at all of our privileges and we found the 3 departments that included this language and have made revisions to the language in all 3 of those departments.
Great.
Because
So it's
because these privileges, all 3 of these departments don't have, they're not due for privilege revision. So we specifically looked to see where this existed so we could change the language.
great. And thank you. That's all I wondered.
Yeah.
I was wondering, under the chief of service, it sounds like that UC's main campus took back our chief of service, and then now we have, appointed an acting chief of service. Are we then going to be in the process of soliciting it, or is the acting chief at UC going to be coming back?
That is a great question, and I don't know the answer to that. I don't know if Dr. Ehrlicher or I believe Dr. Day is on the phone, if you know the answer to that question. Or was there a retirement over it?
Dr. Fuentes Affleck can answer that question.
Oh, wonderful. Yes, sorry, I
Yes.
forgot.
Great.
you.
Thank you, Dr. Horton. So, hello, commissioners. Glad to be with you. Dr. Rebecca Jackson has assured me that it is her intention to cover the department. The outgoing chair rather abruptly announced that she was leaving to become dean at Rutgers University. And so Dr. Jackson accepted the dean's request to be the interim chair, but it is her intention to return. That's why we are asking your consideration of appointing Dr. Steinauer as acting chief, because Dr. Jackson does intend to return. But the search process will probably take a year.
Okay, well, it's helpful to know that we're not going to need to do the search, but that UC would do it for the UC department, right? As versus ours, and that she wants to return here.
Correct.
That's wonderful.
But Dr. Chow, you're absolutely right that we have a really wonderful group of people in the faculty positions at OB-GYN, and they're leading many, many different efforts. So I feel really lucky. I think we had a different faculty member who was acting for Dr. Jackson the last time she had to take a medical leave. And I think it's a really wonderful team that they have there. It's very supportive, but also great leaders.
Great. So let's vote on the chief of service separately, and then we can take up the other issues all in one motion. But it would seem that we should have a separate motion on the acting chief of or acting chair of OBGYN.
And commissioners, all we need is a first and a second motion, and then that's all done, just because there's only 2 of you here today.
Move to approve.
Okay, and I will second that, and then we will therefore have approved this, and we can move on to a motion to accept the other recommendations.
Move to approve.
And I would second that. Thank you.
Both groups of items are approved. Thank you very much, commissioners, and Dr. Horton for filling in. Okay, to move on to the next item, Dr. Chow?
Yes, please.
Sure. Item 8 is other business. And I'll go ahead and ask for public comment from the person online. If you'd like to make comment on item 8, please press *3. All right, I don't see any hand. We can move on to item 9, public comment. Person on the line, this item is for topics that are not on the agenda. If you'd like to make comment on something that's not on the agenda, this is the time to do it. Press *3 now. Okay, no hand there, commissioners and everyone else. Now we're at a consideration, item 10, a consideration for closed session.
So a motion for consideration closed sessions in order,
So moved.
and I would second that.
Great. That's all we need for that. Person on the line, we will leave you, but we'll be back after the closed session. Everyone else, please give me a few seconds to move this over. Okay, we are back in open session, and commissioners, please consider a motion to disclose or not disclose discussions held in closed session.
So do we
Move
have a
not to dis-
motion?
Move not to disclose.
And I would second that.
All right, we'll take that as an action, and now we are at a consideration for adjournment.
Move to adjourn.
And I will second that. I thank everybody for their participation, and we'll look forward to our next meeting. Thank you.
Thanks.
Have a
Thank you, commissioners. Good night.
lovely day.